Respected chairpersons and my dear friends, I'll straight away go to the topic, or in fact the question which was given to me is TAVR going to replace the surgical aortic valve replacement? So first of all, what is TAVR? TAVR is the transcatheter aortic valve replacement. So around 2 decades prior, when a patient needs an aortic valve replacement, there was only one option of a surgical aortic valve replacement. Now you have this TAVR, which is a minimally invasive procedure which can replace the diseased aortic valve. So this is a small animated video just to show that what we do in TAVR. Here what we've done, it's a balloon expandable valve. So the valve is crimped over a balloon, and here you can see that valve and the balloon is taken from the femoral artery through the aorta and it's being placed across the diseased aortic valve. So you can see here this is the valve, and this is placed across the diseased aortic valve. And once it is properly placed, you can see the proper alignment is being done. And after that, we inflate that balloon. So here the balloon is getting inflated. So once you inflate the balloon, the valve gets expanded, and after that you deflate the balloon and take out the balloon out. So the valve remains there. So this is how you replace the diseased aortic valve with the new TAVR valve. So as we all know that aortic stenosis is the most common cause of degenerative aortic valve, accounts for around 60% of the patients. And there's a strong correlation between the increased age and higher prevalence of severe aortic stenosis. 75 years and old, the prevalence of severe AS is around 3.4%. And these patients, because of the higher age and other comorbidities, are mostly treated conservatively because of the high surgical risk. And but with a very poor outcome, like the 5-year mortality of patients severe AS patients treated conservatively is 55%. And the incidence of heart failure is 17.5% if the LV ejection fraction is less. And even if it is normal, it is around 15.3%. So they continues to have the recurrent heart failure hospitalization, continue to have a poor quality of life and high mortality. So why TAVR? This is an article which was published in the European Heart Journal in 2005. This was the data from the Euro Heart Survey. They've said that the decision making in elderly patients with severe aortic stenosis, why are so many denied surgeries? So they concluded the article saying that there was 33% of the patients were denied of surgery in a severe symptomatic AS patients. The major reasons were older age group and LV dysfunction. So almost 1/3 of the patients, even in the Western population, is denied of surgery, and they continue to have these symptoms. So something has to be done for these patients. So this is how it all started. So it was started in the University Hospital in Rouen in France. There was a 57-year-old male who was in the end-stage severe calcific aortic stenosis. LV ejection fraction was 12%, that is a severe LV dysfunction, refractory cardiogenic shock on multiple inotropes. The patient was considered inoperable by the heart team due to the multi-system failure and shock. And this was the first patient in which Dr. Alan Kribber, who is being considered as the father of TAVR, done the first case in the human person. That's in April 16, 2002, around 23 years ago. It was immediately after the procedure, the patient's BP improved, the aortic gradient decreased, and the patient survived from that crisis. But at that time, most reviewers thought that this will not work, and it's a stupid and unethical idea, and surgery is not good enough for all AS patients. But now we know the rest is history. Today, TAVR is becoming the mainstream therapy, saving lives and improving the quality of life in high-risk and inoperable patients. More than 1 million cases done globally. TAVR is also expanding to low-risk and younger patients. TAVR gave birth to the most impactful and the path-breaking intervention in the history of structural heart intervention. So the first major trial for TAVR was the Partner 1 trial, where they have 2 cohorts. Cohort A with high-risk patients, where TAVR was compared with the surgical aortic valve replacement. And they found that TAVR was non-inferior to surgical aortic valve replacement. The cohort B was patients in inoperable patients, where TAVR was compared with the medical management. And they found that there's 46% mortality reduction with TAVR. The other trial with high-risk cohort was the core valve high-risk study, where TAVR was compared to the surgical aortic valve replacement, and TAVR was found to be superior to surgical aortic valve replacement in all-cause mortality. Then they went ahead with intermediate risk patients. There was two major trials, the PARTNER 2 and the SIR-TAVI. The PARTNER 2, the outcome was similar with TAVR and SAVR in 2 years and in 5-year outcome. But when you do the subgroup analysis in patients who have undergone transfemoral TAVR, that is through the femoral artery, it was found to be superior to surgical aortic valve replacement. And the SIR-TAVI was also the same. It was found to be non-inferior in 2 years and 5-year outcome. They went ahead with another step. They took low-risk patients and they found what will happen when you do TAVR in these patients. And there was the PARTNER 3 trial, where the rate of composite death, stroke, and rehospitalization at 1 year was significantly lower in the TAVR group when compared with the surgical aortic valve replacement. The EVOLUTE low-risk trial the TAVR was found to be non-inferior to surgical aortic valve replacement at 2 years. Now, when you take the low-risk patients, it's always important how long will this outcome last. So you need a longer follow-up data. So there was a 10-year outcome data from the NOTION trial. The NOTION trial, they enrolled the low-risk patients. And they found that there was no significant difference in the two groups when you compare the all-cause mortality, stroke or MI. And in fact, the effective orifice area was larger in the TAVR group when compared with the surgical aortic valve replacement, though the paravalvular leak was slightly higher in the TAVR group. And the structural valve deterioration was more in the SAVR group than the surgical aortic valve replacement group than the TAVR. And the rate of re-intervention was very low and not different between both the groups. So overall, when you analyze all this data, definitely in the surgical aortic TAVR is, in fact, in many subgroups, it is almost equal to the surgical aortic valve replacement or even superior. Now, when you see what the guidelines has to say, this is the 2020 guidelines, where they have given in patients with age between 65 and 80 years, if you don't have any contraindication to do a transfemoral TAVI, then either a TAVR or a surgical aortic valve replacement, both has given a class 1A indication. And if your age is more than 80 years or a life expectancy of less than 10 years and having no contraindication for a transfemoral TAVI, then it is actually preferred over surgical aortic valve replacement and is given a class 1A indication. So we'll see how we will decide. So if you have a severe AS patient, to decide between TAVR and SAVR, first should decide whether you have to go for a mechanical valve or a tissue valve. So if the patient's age is less than 50 years, definitely you'll have to go for a mechanical valve because tissue valves won't last so long. And if your age is more than 65 years, yes, you can go for a tissue valve. Between 50 and 65 years, it is a shared decision whether you want to go for a mechanical valve or a tissue valve. And if you are decided for a tissue valve and the age is less than 65 years, it is better to go for a surgical aortic valve replacement because the long-term outcome till now, TAVR, we have a 10-year outcome, but surgical aortic valve replacement, we have a longer outcome of 20 years and 30 years with good results. And if your age is more than 80 years, then definitely TAVR will be a preferred choice. And between 65 and 80 years, it's a shared decision. And the shared decision, the points which to be decided is whether you can do a transfemoral access, which will favor for a TAVR. What is the surgical risk? In a low risk, you can either go for both the option, but if it's a high risk patient, TAVR will be a better option. Aortic annulus, how much is the calcium of the aortic annulus and the size of the aortic annulus all depends in taking your decision. And the risk of coronary ostium obstruction. If you have a very low coronary height from the aortic annulus, then there's a higher risk for coronary ostium obstruction. So surgical aortic valve will be a better option. And definitely cost, because the cost of TAVR will be much higher when compared with a surgical aortic valve replacement. So my take-home message, the TAVR has revolutionized the treatment of severe aortic stenosis, ideal for elderly and high to intermediate risk patients. Surgical aortic valve replacement remains essential for younger and low risk population. Long-term durability still favors surgical valves. Choice should be individualized based on the anatomy, age, and the risk. TAVR and SAVR will continue to coexist, each with its defined and evolving roles. Thank you.